So good morning, good afternoon, and good evening, everyone. Thank you for joining us for our April of 2021 Global One Health Initiative webinar supported by the NIH Fogarty International Center. Our theme for today's webinar will be Data Science, Integrating Electronic Health Surveillance Systems. And we'll be hearing from Dr. Ning. Dr. Ning is currently co-director of the Translational Data Analytics Institute for Computational Health and Life Sciences Community of Practice and an associate professor of biomedical informatics through the College of Medicine and of computer science and engineering through the College of Engineering here at The Ohio State University. Her lab conducts research on data mining, machine learning, and big data analytics with applications for emerging critical problems in drug discovery, medical informatics, health informatics, and e-commerce. And her research focuses on developing efficient data mining and machine learning methodologies to facilitate rapid and targeted exploration over chemical and biological spaces and effective computational algorithms to analyze medical and healthcare data. Dr. Ning has also won a number of prestigious awards, such as the 10 Years Highest Impact Paper Award at the International Conference of Data Mining in 2020, and the National Olympic Competition of Physics in China in the year 2000, among many others. And after Dr. Ning presents, we will have a Q&A session, so please hold your questions until the end of the presentation. With that, I will hand it over to you, Dr. Ning.
Oh, thank you, Laura. Thank you for the introduction, and thank you for having me here. So I'll go ahead and share my screen. Okay, can you see my screen?
Yes.
Okay, so so my topic is going to be on electronic medical record and how we utilize electronic medical record in order to help the physicians during the clinical decision process. So it's about information retrieval from electronic medical records for recommending search terms to physicians. And actually, I only have materials for half an hour, but in case you have questions, we can discuss more after the presentation. So before the presentation, I want to introduce myself and my lab a little bit more. So we work on artificial intelligence, machine learning, data mining for health applications. So in terms of the applications, we work on drug discovery, like we want to identify drug candidates, which can be developed into drugs, and we use AI algorithms in order to identify such drug candidates in a very fast and efficient way. And also we worked on adverse drug reaction analysis, like after those drugs approved by FDA, and many patients actually take multiple drugs at the same time, and those multiple drugs together can induce some adverse effects that each of the single drugs does not have. So we want to have, we have AI algorithms and machine learning tools in order to predict those kind of unexpected multi-drug side effects. And we have a lot of work on electronic medical record analysis, and I'll be talking about one of them today. But the idea is we want to utilize the information embedded in EMRs, and from there, we want to help the clinical decision process by providing support based on EHR data. And recently, we started working on a very specific disease, Alzheimer's disease, because this is a very popular disease among elderly people. And actually, as for now, we don't have a drug that have been approved in order to treat this disease. So we want to find an existing drug that can be used to treat this disease. So this is for drug repositioning. And also very recently, we have some work on generating, quote unquote, generating new drug, new molecules. So the idea is we want to use AI algorithms and learn from many existing compounds and drugs. And from there, we can design new compounds that can be more promising as a drug candidate. So this is about new molecular structure generation. And if you are familiar with the AI tools from Google, the AlphaFold, they use AI algorithms to predict the 3D structures 3D structures of proteins. Here we have a very similar idea. It's to use AI algorithms to generate or to design new molecule structures. And also we have similar ideas on peptide generation, like instead of generating molecular graphs, we generate peptide sequences. So the idea is from there, we want to design new vaccines and new peptides that can be used to treat disease. And very recently, we also had a new project on COVID-19 disease analysis. So again, the idea is we have the EHR data, the EHR information of all the COVID-19 positive patients. And from their EHR data, we want to understand the disease course. I mean, how people, how the disease progressed among different different patients, among different groups of patients. And from there, we want to understand what is the best strategy to help prevent or to manage those patients. So these are the applications, but the fundamental methodologies behind these applications are actually very similar. And it's based on deep learning, machine learning, and particularly something called the learning to rank, a way to learn how to order different instances in an automated way, and also recommender systems and graph theories. So recommender systems is a very fundamental methodology that we used in a lot of ranking and drug selection methods. And actually, this is also the fundamental algorithm or idea behind today's talk. Just to give you a quick overview of recommender systems. So it sounds like very different from what we see from healthcare applications, but actually the ideas are very transferable, and we can leverage the same idea here in electronic medical record data. So if you go to Amazon, I mean, if you purchase something on Amazon, Amazon will have a section called recommended items, something like this, recommended items similar to what you purchased. And this is the list of items recommended by Amazon that Amazon thinks you will purchase. It's very likely that you will purchase later. So these recommended items are generated by the recommendation engine behind Amazon. And recommender systems are the set of algorithms which are run behind the recommendation engines and which generates these items. So actually, Amazon uses a very specific recommendation algorithm. It's called collaborative filtering. And in our application in EHR, we leverage the ideas of collaborative filtering. So the reason I talk about recommender systems first is, so if you think about Amazon, on Amazon, there are millions of products and you are searching for the product that you like and you want to purchase. So from the user's perspective, it's a search activity. You look for information that is most useful to you. But from Amazon aspect, from their side, they want to push the most useful information to you in order to increase their revenue. So the push aspect of is kind of it's complementary to the information retrieval because it can save you a lot of time. And if the recommendation algorithm is very accurate, then you don't need to search, but you will get what you want. So this is a way to provide information to the users that are most customized to the user, and that is most customized to the user and most in a very efficient way. So if you look at the our current EHR system, electronic medical record system, we also have a huge amount of information. Like for each patient, we may have more than 10 years of information, and for some patients, we have millions of data points. I mean, all the drugs, all the visits, all the encounters, I mean, it could be a huge amount of data points. So this is EHR system itself can be considered as a huge information system. And when the physicians look for certain information on the patient from his EHR data, we can consider this as an information search exercise. It's like customers on Amazon searches for products, and in the EHR system, the physicians search for useful EHR information for a particular patient. So this is a search exercise. But similarly to Amazon, in the EHR system, it's a huge amount of information, and oftentimes physicians have to search for similar information for similar patients. And we were thinking, what if we have a recommendation engine sitting behind the EHR system, and that recommendation engine can understand what is the most useful information for this particular patient in order to help the physicians make the right decision. So that would be very helpful, and that will save a lot of time from the physicians, and hopefully that can also help make the right clinical decision. So that's the motivation, that's the connection why we want to make a recommender system behind the EHR. So again, come back to the recommender systems. So this is a quick overview, and I want to tell you some very basic but very effective ideas in order to make very accurate recommendations. So the recommendation algorithms, particularly the top N recommendation algorithms, which recommend the N most likely, most possible items that user may purchase. So these top N recommendation algorithms can be broadly classified into two types. The first one is something called neighborhood-based clutter filtering. So the idea is actually very straightforward. So if you look at the similar, so the idea is we look at the similar customers and look at what kind of products they purchased before, and recommend those items to another similar customer. It's like similar mind think alike. Similar customers purchase similar things. So if we know which customers are similar to the customer of our interest, then we recommend the items from those similar customers. So in the EHR system, it becomes, we want to look for, the physicians may want to look for similar information from similar patients. Like if two patients have similar disease or similar health histories or similar medications, if the patient shares some similarities, then the physicians may want to search for very similar information on those similar patients. So this is a very classical neighborhood-based clutter filtering idea. And the second idea is something called model-based method. So that will involve a lot of learning things, like we want to learn what users like. But when we say learn, probably we need to represent the user's preference in a computable way, such that the computers can understand. So that will involve a lot of representation learning, or ways to represent the user's preference, and ways to represent the item properties and somehow match the user preference to the item properties. So that's the model-based method, and that will involve some probably non-trivial machine learning tools. And actually, recommendation algorithms have been applied in a lot of healthcare applications. For example, personalized healthcare, like the physicians want to recommend different healthcare exercises to different patients, and tailored health communications, like the, for example, some healthcare companies want to send some information to the patients, and the information will be like, for example, the diet information or the exercise routines, that type of general healthcare information, but information is tailored to each physician, to each patient, and ways the information is communicated is always customized. For some patients, they will send emails. For some patients, they will send just mails. And also like home medical products, personalized recipe. So it's like people are different, and when we want to improve the health care for different patients, for different people, the healthcare plans are always customized to each patient, and the customization is done through the recommendation algorithms, particularly through some ranking or ordering algorithms. So the idea is recommendation algorithms can be a very effective tools, particularly for personalized medicine, because in the end, we need to customize everything to each patient. So in our application, we customize the search routine, we customize the recommended information items to each physician on each patient. So that's the whole idea behind information retrieval and recommendation from electronic medical records, this particular work. So so the entire idea is to have a recommendation engine sitting behind the EHR system. So the recommendation engine can do the information retrieval and can recommend the most useful information items from the electronic medical records to the physicians when the physician searches for patient information from the EHR. So that's the very high level overall idea. And actually, we have been implementing this algorithm in a real EHR system, and we have some actually, it's in the emergency department in 2 hospitals now, and we have some physicians and residencies evaluating our method, our system at this point. So this is an overview of our system and algorithm. So let's see. So we start from the EHR system, start from the EHR search terms, sorry. EHR search terms. So in the EHR system, the system always logs what people do in the system, like which patient searches, what kind of information at which time on which patient. So this is information logged in the search logs. So it's about all the search activities and search terms and the corresponding timestamp. So we utilize such information plus actually the EHR data of the patients in order to do the information retrieval, in order to do recommendation. So the idea is if a patient, again, if a physician is searching for something, is searching for a particular patient, then our system will recommend the most relevant information items of that patient to the physician by utilizing an algorithm in this way. So given the search log, actually we can have 2 types of information out of the search log, or I mean, we can organize the information in 2 ways. The first way is about the search sequences over time. So for each physician, and each patient, we know what terms are searched from that physician on that patient over time. So we'll have a sequence of search items over time from that physician on the particular patient. And from the search log, we will have all kinds of sequences for different physicians on different patients. So this is a way to organize all the search activities into search sequences. And also, we know we can organize the information as a physician-patient term relation. So the idea is by organizing the information in this way, we know which physician searches which item, which information on which patient. But here we just don't use the timestamp information, and we just ignore the sequencing, the sequential ordering among all these search items on patients. But we just extract all the triplets of physicians, patients, and their search terms. So after we organize the information in these 2 ways, we can do some modeling. So we have 2 ways to model the information from EHR search logs, and in the end, we'll combine these 2 modeling results into our final results. So the first modeling is about the dynamics of the search. So it's about which items will be searched after which item on a particular patients. So if we consider the search logs as a way to reflect how the physicians think about the patient, how the physicians make a diagnosis about patient, then the sequence must tell us something about the diagnosis process or about the thinking process of the physician on the patient. For example, if a physician searches for troponin after EKG, then that must tell us something about the about that physician is thinking about some cardiovascular disease associated with this patient. So that's the reason why she or he searches for troponin after EKG. So the ordering relation among the item sequences must embed some information that is useful for us to tell, or for the recommender system to tell what's going to be the next most likely items that the physician will search on these particular patients. So that's the reason why we want to have a dynamic modeling to model the sequential relations among different search terms. And I'll talk about how we do that later on, but the idea here is to understand which terms will be searched next, giving all the search sequences from the search logs. And the second thing is about the similarity. As I've just mentioned earlier, we have assumption that the physicians will search for similar information items on similar patients. So there must be some similarity measurement among the physicians, among the patients, and among the search terms. So from here, we want to find similar physicians, like physician and also the similar patients. Then we need to have ways to measure the patient similarity and the physician similarities, and from there we can leverage the clutter filtering algorithm. We look at what similar physicians have searched over similar patients, and from there we can identify similar information items, or the most possible information items for our current patient. So this is about dynamic modeling to model the relations or model sequential orderings of the search terms, and also the similarity measurement to identify similar patients and similar physicians. And then we combine these two aspects into some scoring function. So actually we use first order Markov based modeling, model to model the dynamics, and from there we can have a score to measure the possibility of the next item. So for example, we have 100 possible information items, and each of them will get a score, and the highest scored ones will be the most likely, most possible next item, and we can do recommendation based on that. And also, based on the similarity measurement, we can utilize the clutter filtering based method. We find, again, similar patients and similar items, and recommend similar physicians and recommend items from there. So this clutter filtering based method will give us another score on each item. So we'll calculate the score from there based on the similarities among physicians and patients. And giving these two scores, we can combine them into one score, such that each information item will receive one score. And based on these scores, we can sort those information items. And we believe the first at the top, for example, top 10 or top 10 highly scored items will be the most likely information items that the physician will search for. And we recommend those items to the physicians. So this is the overall flow chart of our system, again, based on so in this algorithm, we'll model the dynamics, we'll model the sequential orderings of different information items searched over time, and utilize the similar physicians and the similar patients. So this is the overall framework. But here, I will have a little bit math about how we calculate those scores, but just don't worry about all the math. But here, I just want to use those equations to represent the basic ideas. So first off, it's about the dynamic. We call our method as the dynamic and multi clutter filtering method, because we have a dynamic component, the Markov chain component, and also we have the clutter filtering method based on the similarities. So in the end, for each possible information item that that physicians may want to search, we give that information item a score. And the score is a combination of the score generated from the dynamic part and generated from the clutter filtering part. So it's like we have two ways to model the to score the next possible item, and we just combine the scores from there. And this score will become the score of the next possible search term. And for all the search terms, we just sort them based on scores and recommend the top ones. So that's the whole idea. And for the dynamic part, we use something called a first order Markov chain. So the idea of Markov chain is also very simple, I would say. So the idea is the probability that the idea is the next item you want to search only depends on the previous item that you searched, and it's irrelevant to anything earlier. So, or in other words, the next item you are search is only determined by the current item you are searching for. So that's the very simplified assumption behind Markov chain. So here, based on the Markov chain, we will give the next possible search term a score, and the score is only calculated from the previous search term. And this is a huge equation in order to calculate the score, but the idea is it's going to be how likely this search term is searched after its previous search term divided by all the possible search terms. So that's the idea. So based on first order Markov chain. And the second one is about the clutter filtering part. So we need to utilize physician similarity, patient similarity, and utilize those similarities in order to calculate a score for the next possible search term. So again, it's a very big equation here, but the idea here is, for the next possible search term T, the score from clutter filtering component is calculated by two components, actually, by two parts. The first part is how often Y searches, how often the physician searches on the particular patient. I mean, how many search terms have been there for from these physicians on this particular patient. So this is like a baseline. And this is a kind of a baseline of this patient, of this physician on this patient, plus something. And this second term here is based on the clutter filtering idea. So here, again, the idea is we look at similar physicians and look at similar patients, and from the similar physician, and we'll look at what kind of search terms those similar physicians have searched on similar patients, and use their frequencies as a way to score the next possible search term key. And this is the second big term is nothing about the search term frequency from similar physicians over similar patients. And by combining these two components, we gave the next search term of a score from the similar physicians and the similar patients. So this is the second idea. And in the end, we will combine these two scores together to give a next search term a possible score, and again sort them and recommend the top ones. So here I want to show some quick examples. So we use the data from Indiana Network for Patient Care. So this is a network including, I believe, all the health systems in the state of Indiana. So in Indiana, they centralize all the data, all the EHR data from all the healthcare systems in the entire state. So if a patient has multiple EHR records from different healthcare systems, from different hospitals, all the information will be connected and centralized at one server. So that's a very nice thing, because we can have a very complete view of each patient in this entire state. And we extracted the IMPC search log data between, I believe this is about 8 months in 2013. And this table 1 will give you some quick idea about how many patients we have. So in total, we will have about 14K patients and 2K physicians. And among those patients, there are about 10K search terms over time. And this is about the search log data. And in the search log data, we use different cutoff time. So for example, we use June 26, 2013 as a cutoff cutoff time, such that all the data before this cutoff time will be used as training data, and all the data after this cutoff time will be used as test data. So this is a way to simulate some real applications, like we use everything before a certain time as training in order to predict everything after a certain cutoff time. So we tried different cutoff times. So this will give us different training and testing test data sets, and we can evaluate our algorithms over different training and test sets. And this big table just shows some very quick example experimental results. And this DMCP, this is our method, but we also have some other baseline method. For example, only based on dynamics, based on the first order Markov chain, only based on clutter filtering, based on similar patients and similar physicians, and also some other baseline methods. And we evaluate our method based on something called hit rate at N, hit rate at K. So the idea is if we recommend K different items, and among those K different items, we look at how many of them are actually really searched by the physician. So if the physician did search for certain items among top K, then there is a hit among the top K. So if we recommend 5 and the physician searched 3 of them, then the hit rate will be 3 over the hit rate. There is a hit among those top 5 recommended items. So actually, in our case, about 47% of the patients will have the search terms among the top 5 recommended search terms. So in other words, for about half of the patients, if we recommend 5 search terms, the physicians did search at least one of the search terms among our top 5 recommendations. So that's the overall idea of the results. And we also had different comparison on different cutoff times, and the results are pretty consistent. That is, if we use both the dynamic component and also the clutter filtering component, we can have a very nice hit rate for many for the patients. Also, if we compare with only the dynamics and only the clutter filtering methods, none of them is good enough unless we combine both of them. That means when we consider how to recommend information in order to support clinical decision making, we need to look at how this physician performs over time, how this particular physician searches over time, and also we need to look at how other similar physicians search over time over similar patients. And if we combine these two, we will have a good chance to find the most useful and accurate information for that physician. So that's probably the most important take-home message here. And just some acknowledgements to the funding agents and also our collaborators and all the students and postdocs who have been who have a lot on this particular work, and some very interesting references for you if you are interested, particularly on recommender systems in general, and also on recommender system for healthcare applications. I think that's what I have as for now. So if you have any questions, I'm very happy to take the questions.
Thank you so much, Dr. Ning, for this highly relevant presentation. And thank you for breaking things down so nicely for our understanding. I would like to kick us off with a question. Because the systems is able to log searches, is it possible to link the data to surveillance systems or set an alert threshold for related to particular symptoms to trigger early warning systems?
Oh, yes, yes. So the question is if we can have a way to trigger warnings or alerts for particular disease or particular condition. And the answer is yes. Actually, in our case, we use the chest pain as an example. So when we search, when we recommend information items, those information items are very relevant to chest pain, and this is for a application in the emergency department. So the idea, so here we still utilize the search term, sorry, the search sequences, but in order to convert the system into a surveillance system, what we can do is we can quote unquote start the search and automatically using a very frequent or popular items among the physicians, among the patients, and from there we run our algorithm, and if we see a search term, if we see a particular information item is very popular or very dominating among all the physicians, among all the patients, then we can set up alerts saying that this is something common among all the patients. So we can quickly convert the entire recommendation thing into a surveillance or alerting system in that way.
Wow, okay, thank you so much. That's wonderful. All right. We have a second question now. Given the association of data with particular physicians and particular patients, how do you navigate HIPAA requirements?
Oh, HIPAA. So when you say navigate HIPAA requirements, does it mean when we do the recommendation, when we do the calculation, we need to follow the HIPAA requirement, HIPAA criteria? Is that what this question means?
I would think so, but
yeah, yes.
You can raise your hand, whoever asked the question as well, if you would like to speak. And
yes, okay, thank you. So actually our algorithm is, so of course, I mean, every time we utilize the data, we need to follow all the regulation and all the requirements by HIPAA. Our algorithm does not, we treat all the information as a black box. I mean, we don't really explicitly recognize, hey, this is a HIPAA information item, this is not, this is a zip code, this is the birth date of a patient. So we don't explicitly recognize the HIPAA information there, but we treat all the information as information. And since this algorithm is running within the HR system, so we assume that there is a HIPAA requirement, HIPAA regulation already implemented in the HR system. So we don't really particularly deal with the HIPAA data here. We just treat HIPAA information as a certain type of information. And if in the end, for example, the birth date is prioritized or recommended to the physician, then we will just show that to the physician. So we don't really explicitly differentiate between HIPAA or non-HIPAA data when we do the recommendation. We treat them as the same. I mean, we treat them equally. I mean, we don't particularly deal with HIPAA information.
Excellent.
I hope that answered the question.
Yeah, I think it did for me. All right. So any other additional questions? We'll give everyone a few minutes to gather their questions.
Yes, and actually, we also had a very interesting observation based on our real evaluation from physicians. So sometimes we recommend something and physicians just treat them as alerts, like they think we recommend some information item that they say, oh, this is important. It's like alerting, alert physicians to pay attention to that particular item. So from that perspective, you can consider this, you can also convert this as a surveillance or alerting system, but to the physician now. Yeah, that's a very interesting aspect. And also we observe that physicians also want to know why we recommend that information item. So that's why in the end, we have to link some additional information to the information we recommend. For example, if we recommend troponin, then to the link of the, we need to, we have a link to the troponin showing that this patient have had some troponin issues in the past, or some related information, so that becomes some supporting information for our recommended items, or some evidence for the recommended items. And we found that physicians really like that. They need additional evidence to show why this item is recommended to me.
Very interesting. I guess another question I have is, have you had any opportunity to try to implement internationally, or where has most of this work been applied thus far?
Oh, yes. So as far as for now, it's only implemented within IMPC, and actually only within 2 emergency departments in 2 hospitals. Not it hasn't been implemented in a very wide wide scale, and not definitely not on the national level. But we would love to say that. And the issue is to implement something like this in the EHR system, it's very not so trivial. I would say it's kind of complicated, because we need to improve some. We need to implement something, plug something within the existing health system. So there will be a lot of interface type of things, and a lot of interactions with the EHR databases, and that's not an easy thing to do as for now. So even within those 2 emergency departments, we had a lot of implementation issues, like we need to get data, and we need to do a lot of computation over the data. So you don't want your computation to interfere the EHR system operation, and you don't want to have a lot of latency, because we want to recommend things in real time. That's also the challenge part. So it's a lot of interface, a lot of data retrieval, real-time calculation, those things. It's not a trivial task, I would say. But I would love to see if our system can be implemented in many hospitals, and see whether we can help. We did a kind of very quick math, like if our system can save, for example, 2 minutes for each physician on each patient, then that's going to be a lot of that it can save a lot of effort and a lot of time from the physicians, and we think this is going to be significant. But as for now, it's only implemented and evaluated in a very small scale, only in those 2 hospitals.
Okay, well, there's definitely a lot of opportunity there, so it's a highly valuable tool. So look forward to see its expansion for sure. Do we have any other questions from our audience?
Yeah, so this is something, obviously this is not a very common applications over EHR data. So oftentimes people use EHR data to do some predictive analysis. So they want to look at EHR data of certain disease and patients of certain disease, and predict, for example, which patient will have high risk based on the EHR data, based on the medical history, health history. But in our case, we want to do information retrieval. We want to prioritize all the information items in EHR, and show the most useful, most relevant information from the EHR to the physician. So we convert that as a clinical decision support tool, or hopefully, as Lars mentioned, also as a surveillance tool. So it's, I would say this is a very different application using EHR data compared to the predictive analysis using EHR data. But if you think about the entire EHR system as a system of all the patient information, then probably we can do a lot of things from the information system in order to help the diagnosis process, to speed up the diagnosis process, to make the diagnosis more accurate, and provide more support evidence for any diagnosis that patient and the diagnosis the physicians make. So I think that's another different probably perspective about how we can utilize EHR information, EHR data to help improve healthcare.
Such an incredibly useful tool. So many different opportunities.
Yes.
If we have no further questions, I think we can convene. So thank you so much for your wonderful presentation. This is truly fascinating and so valuable. And with that, we look forward to seeing everyone for our May webinar. And I hope you all enjoy the rest of your day. And thank you so much again, Dr. Ning.
Thank you for having me.